So I'm here to present on excessive bleeding in women with a spotlight on hemophilia carriers. These are my disclosures. I would like to thank the organizers of Rendez-vous for the honor of presenting to you all today, and to personally thank David Page and Pam Walton for inviting me. So today I'm going to review what we know about hemophilia carriers, explore barriers to care, optimize care based on current knowledge, what we do not know about hemophilia carriers, and some future directions. So let's start with what we know about hemophilia carriers. So let's start with the ancient history of hemophilia, something that is familiar to everyone in this audience. So hemophilia was recognized as a bleeding tendency in men, and this was recognized as early as the Talmud in the 2nd century AD. Otto identified hemophilia as being a hereditary disorder that predominantly involved males and traced the disease back to a woman who was thought to be a carrier. In 1828, Hoff was the first to use the term hemophilia. And then perhaps the most famous hemophilia carrier, Queen Victoria, resulted in hemophilia being known as the royal disease, as it went through many different royal families. So the traditional view of hemophilia is that in general, men are affected with the disease and women are carriers. And this implies that women are unaffected. But do hemophilia carriers bleed? Well, we know with the use of validated bleeding assessment tools to quantify the bleeding history that carriers have increased bleeding scores as compared to controls. And the bleeding is predominantly mucocutaneous, meaning nosebleeds, heavy menstrual bleeding being the most common symptom, in fact, bleeding with procedures and postpartum hemorrhage. But we know that the majority of hemophilia carriers have levels between 0.4 and 0.6 units per milliliter, or 40 to 60%, which is generally considered as being adequate for hemostasis. Also, there are reports of bleeding symptoms even with completely normal factor levels. So further to this, there's an international prospective cross-sectional study that was led by Paula James, as well as an international group, that confirmed that 38% of carriers have abnormal bleeding. And in fact, their bleeding scores were less than patients with type 1 von Willebrand disease, but more than obligate carriers of type 3 von Willebrand disease, and certainly more than controls. They also show that there's less mucocutaneous bleeding in hemophilia carriers as compared to type 1 von Willebrand disease patients. And they also confirmed that there is abnormal bleeding experienced by hemophilia carriers. Most interestingly, that there's musculoskeletal bleeding, as there were numerous reports of hemarthrosis. And this led the authors to conclude that their findings contribute to the evolving understanding of bleeding in hemophilia carriers. So let's explore the musculoskeletal bleeding a little bit more, and I've incorporated the data from this international study. So somewhere between 9 to 19% of hemophilia A carriers report hemarthrosis, and it's reported in some with totally normal factor levels. Also, there's an association between deficiency of factor 8 and factor 9 in hemophilia carriers and reduced joint range of motion. And this reduced joint range of motion was noted as early as the preteen years. So this suggests musculoskeletal bleeding that is subclinical that is occurring in carriers. We're picking something up here by this reduced joint range of motion. Another study, which was the first prospective study of joint range of motion abnormality in carriers and also assessed for radiologic evidence of damage using imaging techniques, and they show that hemophilia A carriers have evidence of structural joint damage. And the joints that were most commonly affected are the ankle, the elbow, and the knee. And these are the joints that we know to be most commonly affected in men with hemophilia. So what is a normal coagulation factor activity level? So we know in the general population that factor levels vary between 0.5 and 1.5, or 50 to 150%. So there's pretty wide variation. There's also wide variation in factor activity levels of carriers, but we know that the mean factor activity level in carriers when compared to the general population is lower. We also know that 30% of carriers have low coagulation factor levels. So what could account for this variability in the carrier factor level? There are many reasons why. So maybe this is all lab related. So perhaps it's just because you get a variable result depending on the type of assay that you're using. If you're using a one-stage PTT-based assay versus a chromogenic assay, we know with particular mutations of hemophilia that there can be significant variability in the factor activity obtained using these different instruments. Lionization is another factor. So you can have skewed X chromosome inactivation. So let's say the unaffected chromosome is more inactivated than the other one, and that could lead to more of an expression of low factor activity levels. ABO blood type, von Willebrand factor mutation presence and severity, also compound heterozygosity or homozygosity. Say, for example, a carrier mother marries or gets into a relationship with a man who's affected. Sorry, I'm trying to be progressive here. Okay. I won't get too racy. So let's say they get it on and and have a child, and that child can carry two of the same mutated copies or two different, and they can have lower levels. Okay, I'm going to pull it together. What about Turner's mosaicism? So a really, really rare disorder where a woman has only one X chromosome. Obviously, that's crazy rare, and a bunch of other unknown variables. So there's more to the story than the coagulation factor level alone. And this was really nicely and elegantly shown in the international study that I alluded to earlier. They show that there's a significant but weak negative correlation between factor levels and the bleeding score. So this is an important principle. The factor level is a factor. It's a contributing factor, but it's not the only factor. And I think that that's a pretty important paradigm shift. To highlight yet another great study that was done by our Canadian colleagues at Sick Kids, led by Emmanuel Carqueo, they reinforce that sometimes it's difficult to make the diagnosis. And that's because factor VIII levels in hemophilia A carriers can be quite variable. I know I'm focusing a lot on hemophilia A carriers just because there's been more research done because it's a more common disorder. And these factor levels can be quite variable, and we know that a normal factor VIII level does not rule out the possibility of carriership, and that mutation analysis is truly the gold standard to make the diagnosis. But what if you're in a resource-poor setting and you don't have access to genetic testing? And sometimes it does take a little bit of time before you get the genetic testing back. We're very fortunate in Canada to have access to genetic testing quite readily, but we also can't heavily tax our colleagues in Kingston all the time. Sometimes we need to know results sooner rather than later. And so in this study, they looked at carriers, so female family members of boys with hemophilia A at Sick Kids, and they identified that a factor VIII to von Willebrand factor antigen ratio performed better than factor VIII alone in identifying hemophilia A carriers. So they found that this ratio was lower in carriers as compared to non-carriers, and it was a statistically significant result. So we know that our factor levels vary with various physiologic states. So we are rigged from an evolutionary perspective to increase some of our clotting factor levels in response to stress. And this makes sense if we think back to ourselves as hunters and gatherers, running through the jungle or the woods, being chased by some animal or perhaps chasing an animal. Our sympathetic nervous system gets activated, we get amped, some of our clotting factors increase in response to that to protect us against that potentially fatal impending bleed from a wound that may be coming up. And so there's a lot of physiologic variation that can occur with factor levels, particularly with factor VIII and von Willebrand factor. And another example of an important physiologic state is pregnancy. So again, women are rigged throughout their entire pregnancy to increase some of these clotting factor levels to protect her from a potential significant bleed that occurs at childbirth. And so if we look at what happens to carriers over the course of pregnancy and see, well, what happens to her factor levels? Well, we see that there is often an appreciable increase in factor VIII levels in hemophilia A carriers. So pre-pregnancy baseline levels in this study, 46%, third trimester, 121%, a nice increment in the majority of patients. In patients who are carriers of hemophilia B, on the other hand, there is an increase as compared to pre-pregnancy levels, 31 to 48% in the third trimester. So there is a bit of a bump, but not as much. So they found in this study that 8% of carriers of hemophilia A had a factor VIII level of less than 50% at delivery, and 50% of carriers of hemophilia B had factor IX levels of less than 50% at delivery. And we generally say that 50%, right, is our threshold for normal. But is 50% truly enough? I said that from an evolutionary perspective, we are rigged to increase our clotting factor levels. If you were to test a control patient, somebody who was unaffected, her factor levels in her third trimester might be 250%. So is 50% enough? I don't know. And what's important is that this puts patients who are carriers of hemophilia at increased risk for postpartum hemorrhage. And this study showed a high incidence of primary postpartum hemorrhage, so bleeding early after childbirth, despite specialized care in a hemophilia treatment center. So despite our best efforts, women are still experiencing bleeding postpartum. And this is particularly true for women with low factor levels in third trimester. So even at our HTCs, there's opportunity for improvement. Another important consequence is iron deficiency. So iron deficiency results or can result as a result of chronic blood loss. And then iron deficiency anemia develops when the iron levels are so low that interferes with the person's ability to produce red blood cells. And this is a very common finding in women with heavy menstrual bleeding because that individual has bled every single month of their lives since they first got their period. And the most common symptoms of iron deficiency, even in the absence of anemia, is fatigued and decreased concentration that contributes to decreased health-related quality of life. And this has been shown repeatedly in the literature. This is so important that the CDC recommends that all non-pregnant women should be assessed for anemia every 5 to 10 years throughout their childbearing years during routine health examinations. But women with risk factors are recommended for annual objective testing with an iron check, a ferritin check, and a CBC. So what are these important risk factors? Race, poverty, low education, low iron intake, because iron-rich foods are expensive, heavy menses, an underlying bleeding disorder, parity, which is pregnancy, previous diagnosis of iron deficiency anemia, and body mass index, actually being overweight or obese is a risk factor for iron deficiency. So we must individualize care. We must identify patients with additional risk factors and treat these individuals. I think what's really important to note when you look at these risk factors is that there is a mismatch between who gets iron supplementation and who needs it, because the impoverished, poorly educated woman is less likely to have access to healthcare, less likely to be self-empowered, less likely to be able to pay for her iron supplementation. Iron deficiency and neuropsychological symptoms, they reverse entirely with treatment. And this has been shown in a fairly recent meta-analysis of 14 randomized control trials that show that there's an improvement in attention, concentration, which results in improvement in IQ with iron supplementation in iron deficient women. So that leads to improved potential, self-esteem, empowerment, productivity. I can go on and on. Not to mention that the best and safest transfusion is the one that's not given. So iron supplementation is critical to decrease the amount of red blood cells that these women are receiving unnecessarily. Now let's explore some barriers to care. So what does it mean to be a hemophilia carrier? So the traditional view is that in general, men are affected with the disease and women are carriers. But there is a disconnect between the term carrier and reality for some women. But there is experiential variability. Not every woman who carries the hemophilia mutation has the same experience. There's also variability in self-perception, self-awareness, self-care, which leads to reporting bias. And there's also a difference in patient versus healthcare provider impressions. And this variability in the patient and in the healthcare provider in combination with the carrier label may pose a barrier for care in women with excessive bleeding and those who are about to undergo a hemostatic challenge. So the label may pose a barrier to care for some of these women. Let's talk about mild hemophilia, the definition for a second. So mild hemophilia is defined as a clotting factor level of less than 40% down to 5%. But we know that risk of bleeding occurs at factor levels above 40%. And so why is it that we use a different term for a woman that is affected? So what is the best term? Is it truly symptomatic carrier? Is it female with low factor activity level, or purely person with hemophilia? I don't know the answer to this, and it's probably because it depends. Also, the medical understanding of carrier bleeding is incomplete, and that is because the literature is limited. It's also rife with conflicting data. And there's also this inconsistent correlation with factor activity and bleeding symptom severity, which intuitively is very hard to wrap one's mind around. Also, some principles of hemophilia-based care simply do not apply to women, and that is because every woman bleeds naturally, so women cannot be bleed-free. So we have to define the concept of normal bleeding, which is really, really difficult because women tend not to talk about their menstrual bleeding. There's also skepticism that exists amongst healthcare providers because of all of this. There's also a lack of a standardized approach, which can also pose a barrier. So these bleeding assessment tools that I was referring to have fairly recently been validated for carriers, but they're very helpful. There's also a lack of consistency in the timing of the assessment. There's no unified recommendation on when should we test for the presence of carrier status. It seems reasonable to consider carrier testing before menstruation, prior to procedures, but should we be doing it earlier? Because sometimes in life, you just don't know what's going to happen. I think we can agree that pregnancy is really not the ideal time for initial testing because those clotting factor levels can increase and you may miss the diagnosis, particularly if you're relying on a normal factor level as excluding the disease. Carriers also may not be followed at HTCs. They may not be aware of their factor levels and they may not have had genetic testing, so they just may not know. So the consequences of these symptoms and barriers to care lead to decreased health-related quality of life on the basis of stigmatization, diminished access to care, heavy menstrual bleeding, iron deficiency, and anemia that results, and possibly musculoskeletal disability. And there's also the perception of negative experiences with the healthcare system. I'm going to highlight another nice Canadian study here from Halifax that was a qualitative study that looked at emotional and behavioral responses to medical experiences discussed by carriers. Now, I really can't read what I've circled around there, but basically this woman was angry. She felt frustrated. She did not have a good interaction with her medical health professionals. This one, I'm describing behavioral responses. Here, one of the women describes being told that she should not have a medical alert bracelet or a wallet card identifier, that it would be a waste of money and time. And this model of negative feedback loop of negative medical experiences leads to a vicious cycle. And what's important is that this leads to not only negative personal experiences, but also negative collective experiences. Another important possibly negative cycle is the story of iron debt. So with every normal menstrual bleed, a woman loses about 10 to 20 milligrams of elemental iron. And when a woman is pregnant, she loses, because she provides that iron to her baby, about 1 gram of iron. So it's pretty iron depleting, particularly if you have poorly nourished heavy menstrual bleeding and quick succession pregnancies. It can be rapidly iron depleting. So is iron deficiency anemia a social justice issue? The answer, unfortunately, is yes. We know that worldwide, the women who have the highest prevalence of iron deficiency anemia, and this is in women who are tested, are those of reproductive age. And reproductive age is the time when women are going to be most productive in their lives, contributing to society, and et cetera. So this model of negative feedback for the patient contributes to the larger public health issue of uncontrolled iron deficiency anemia in women. So I talked about a lot of negative things. Now, how can we optimize care based on our current knowledge? A multidisciplinary approach, I think many of us believe, is critical. And carriers and women with hemophilia can safely be cared for at HTCs. And another important Canadian hematologist in the audience was the first author here. The multimodal approach that involves the patient is also critical. So some fantastic work has been done, again, through Paula's team. There's now a Let's Talk Period website that really empowers women with bleeding problems. Whether or not she has or has not a disorder, she can actually go through a bleeding assessment tool on her own and show up to her hematology appointment with the result, which is pretty incredible. So all of these things enhance education and awareness and self-perception and self-advocacy skills. At St. Michael's Hospital, I'm very proud to say that we do have a multidisciplinary clinic that involves myself, a pediatric hematologist, Jillian Baker, an obstetrician gynecologist, Philomena Meffy, an anesthesiologist, Rachel Martin, and Georgina Floros, our nurse manager, and Antoinette, our wonderful administrator. And we put together treatment plans that are quite comprehensive. And not only do we put this in the patient's chart and notify the entire team, but we also give the patient a copy should she deliver somewhere unexpected. I think what's really important when we're optimizing care based on current knowledge is to stay current. So this study was just recently published, a pretty important study, a large randomized controlled trial, double-blind, placebo-controlled from 2010-2016, and over 20,000 women with postpartum hemorrhage were included in this study. And they randomized these women to either receiving tranexamic acid or cyclopropin, which is a medication that many in the room are familiar with, versus placebo. And these are in all comers, so women who are not known to have a bleeding disorder. And in these women, death due to bleeding was reduced in women who were given tranexamic acid, especially when given early. So a simple yet really important intervention. And we definitely include the use of tranexamic acid in our care plans. And I know we're not alone. So what do we not know about hemophilia carrier? So these are just some of the unanswered questions, but there are many more than just this. So what are the genetic and environmental influences on the expression of bleeding in hemophilia carriers? Are there any predictors of bleeding in hemophilia carriers? How prevalent is musculoskeletal bleeding, diminished joint function in hemophilia carriers? Do carriers of hemophilia A bleed less than carriers of hemophilia B? Is there an increased risk of miscarriage in carriers? These are all things that we don't know. Also, this factor level issue is a really big conundrum. So is a factor level of 50% normal? Well, in what circumstance? The rise of factor VIII and factor IX in pregnancy is variable, inconsistent, and unpredictable. Why? What is a safe factor level for labor and delivery and for procedures if the bleeding phenotype does not always correlate with the factor level? So what is our goal? There are also other possible predictors. So maybe the genotype. There's been a lot of conflicting data in the literature thus far on that. Maybe inherited thrombophilias, platelet dysfunction, global hemostasis issues. I could go on and on. There's also this continuum concept, which has been described in the literature in some opinion pieces where they talked about, perhaps the bleeding risk changes based on the variability of factor VIII and factor IX, just as it moves up and down the scale. But I was inspired by the paper that was published, the international study that I alluded to that Paula was involved in. I wonder, maybe it's not just as simple as the continuum concept. Maybe there's also a contribution concept, right? So maybe it scales up and down, but maybe it's just one piece of the puzzle. So I think it's important for us to not be overly simplistic. And do we change the label and or label patients early? So the pros to that, to test early prior to menarche, you're armed with knowledge, proactively identify risk, mitigate excessive bleeding risk and complications. But the cons are as over-medicalization for those who do not need care, and there may be important insurance coverage ramifications. So some future directions include to continue enhancing awareness, education, support, and self-empowerment for carriers of hemophilia. More research is desperately needed, and a larger study is warranted. And the Canadian response to this is a large multi-center study called the Canadian Hemophilia Carrier Study, led by Paula James and Alfonso Iorio, to address a multitude of these unanswered questions. So Canada is truly on the forefront here. So in summary, there's increasing awareness that many hemophilia carriers experience abnormal bleeding. Bleeding is likely underreported and underrepresented, and it's important for us to sort of cue into the possibility of musculoskeletal bleeding in our patients. The term carrier likely does a disservice to those who are affected. There are important complications that can occur. It requires comprehensive support and multimodal change strategies. And there's really no clear explanation to date for the variation in bleeding phenotype amongst carriers, and more information is needed. So I'd like to thank you all for your attention, and I'd like to actually send a call out to women who are carriers in the audience to say that more research is needed so that we can improve your care. So I would implore you to be involved in research studies so we can do better. Thank you.